Okay, so for today's deep dive, we're starting with a source that, on the surface, sounds incredibly niche, but it's actually a masterclass in visual pattern recognition. We're breaking down a video from Dr. G.S. Raju's YouTube.
It really is. It's a fascinating piece of medical education because it's all about one of the most high-stakes environments in medicine, the colonoscopy.
And usually, you hear medical topic and you expect what? Biochemistry, genetics.
Yeah.
But this is all about geography. It's topography. It's about looking at a landscape, the lining of the colon, and trying to figure out if that bump you're looking at is, I don't know, a harmless hill or volcano about to erupt.
That is the absolute core challenge. When you're an endoscopist, you're navigating this tube, and the scenery is just constantly changing.
Yeah.
The mission here for us is to understand the system doctors use to make sense of all that chaos.
And that system is called the Paris classification.
The Paris classification, yeah.
It sounds like a peace treaty or something, or a Fashion Week event.
It's significantly less glamorous, I promise you. It's the global standard for describing the morphology, so the shape and the structure of these superficial lesions in the GI tract.
And the reason we're diving into this specific source is that Dr. Raju gives you this amazing visualization system to decode it. It's not just memorizing codes like 1P, 1s, 2A. He turns it into a story about how a lesion changes under pressure.
That's the key, because medical textbooks, they just give you these static boxes. Type 1 is this, type 2 is that. But Dr. Raju's approach, it lets you see the progression. It connects the dots between a benign-looking polyp and a dangerous invasive cancer using this really tactile analogy.
Okay, let's get right into that analogy. The source basically anchors everything to one simple shape.
The mushroom.
The mushroom.
It's the classic starting point. At the Paris classification, this is your type 1P lesion. The P stands for pedunculated.
Pedunculated, which basically just means it has a foot, a stalk.
Correct. You've got a distinct head, the cap of the mushroom, and then the stalk attaching it to the colon wall. And that's not just a description, it's a critical distinction for risk.
Because of where the danger is.
Exactly where the danger is. With a type 1P, the dysplastic, or the cancerous tissue, is almost always contained within the head. The stalk is usually just normal tissue.
Huh. So it's almost like the polyp is holding the cancer up in the air away from the body.
That's a great way to put it. It's a buffer zone. And from a procedural standpoint, this is the best case scenario for removal.
Right.
The doctor can just loop a snare around the stalk and cut it. If you get a clean cut through that stalk, you've removed the entire threat.
You're just harvesting the mushroom.
You are, but you have to be precise. The source makes a good point that you can't just hack at it. You have to sever that stalk cleanly, because if you leave any piece of the head behind, you've left the potential cancer. But that 1P gives you a huge advantage. Separation.
So that's our starting point, the tall, standing mushroom. Now, this is where the source introduces the visualization I loved, the hammer.
Ah, the compression analogy.
Yes. So imagine you take a hammer and you just strike the top of that mushroom. You're not cutting it, you're just squashing it. What happens to it?
Well, the head gets pushed down, and the stalk, it doesn't just disappear. It gets shorter, wider, it sort of bells out.
And that gives us the next category.
That is your type 1SP, the semi-pedunculated polyp.
So it's different because that safety buffer, the stalk, is being compromised.
It's diminishing, yeah. You still have some separation from the colon wall, but it's not that long, thin stalk anymore. It's a thick, squat connection.
Which I'm guessing makes removal trickier. You don't have as much room to work if you're trying to snare it.
Precisely. The margin for error gets smaller as the stalk gets smaller. But let's keep going with the hammer.
Okay, so we're not done. We hit it again, harder this time. We smash that mushroom down until the stalk is pretty much gone. The head is just sitting right on the mucosa.
And now you've arrived at type 1s, the sessile polyp.
Sessile, meaning seated.
Yes, and the definition is really specific here. A sessile polyp is one where the base is as wide or wider than the top. No stalk. But it's still clearly protruding. It sticks up.
But sticks up feels so subjective, doesn't it? I mean, you're looking through the fisheye lens of an endoscope. How does a doctor know if it's protruding enough to be a 1s versus something flatter?
That's a great question. The optics can be very deceiving. So Dr. Raju points out this incredibly practical tool they use for standardization.
Which is?
The biopsy forceps.
The little claw tool they use for samples.
Right. It's not just a grabber, it's a ruler. The closed cups of a standard forceps have a known diameter, usually about 2.4 millimeters.
So they actually use it as a ruler, a reference scale.
They literally slide the closed forceps right up next to the polyp for a side-by-side comparison. If the height of the polyp is greater than the diameter of those closed forceps, it's classified as a type 1's, a sessile polyp.
That seems, I don't know, shockingly analog. In this world of HD digital imaging, they're just holding a ruler up to it.
It works. It totally reduces variability. Instead of one person saying, that looks tall, you have a binary metric.
Yeah.
Is it taller than the forceps? Yes or no? If yes, it's a 1's.
Okay, so we've gone from the tall 1P, hammered to the squat 1SP, then again to the lump-like ones. But the hammer keeps going, we're going to flatten this thing even more.
And now we cross a really major threshold in the Paris classification. We move from protruding lesions, which are type 1.
To superficial lesions, type 2.
Exactly. And the first one we hit is type 2A, the superficial elevated lesion.
Okay, so visually, how is that different from the sessile ones we just talked about?
It's the same hammer concept. You've just pressed it down further. Now, when you put those biopsy forceps next to it,
it's shorter.
the lesion is shorter than the forceps.
So it's like a low plateau.
A slightly raised area of mucosa.
Yeah.
It's distinct, maybe the color's different or the vascular pattern, but geographically it's very low profile.
And this is where the source brought up a subcategory that just sounds a lot more ominous, the laterally spreading tumor, LST.
LSTs are a really fascinating subset of these 2A lesions. Basically, if you have one of these superficial elevated lesions and it grows to be bigger than 10 millimeters across, it gets that title.
The name says it all. It's not growing up, it's growing out.
It's basically carpeting the colon wall. And Dr. Raju distinguishes between two textures here that are super important, the granular type and the non-granular type.
Which is just what it sounds like, bumpy versus smooth.
That's essentially it. Granular looks like it has nodules on it, kind of like a strawberry surface. Non-granular is just smooth.
And does that actually matter? Or is it just descriptive?
Oh, it matters hugely for planning the removal. But the main takeaway for type 2A is that the vertical growth is minimal. It's all about horizontal spread.
Okay, back to our hammer. We've smashed the polyp down to this low plateau. Now we hit it one last time. We flatten it completely.
And this brings us to type 2B, the flat lesion.
And when the source is flat, it means flat.
True flat. The level of the lesion is virtually identical to the surrounding mucosa. Maybe, as Dr. Raju says, a tad bit of difference. But you're really just looking for a discoloration on a flat surface.
That must be incredibly hard to spot.
They're the invisible lesions. You're not looking for a shape anymore. You're looking for a disruption in the pattern, a break in the little blood vessels. It takes a very, very trained eye.
But, and this is where the story gets really dark, we're not done. We can go lower than flat.
We can indent the surface.
Yeah.
And this is the most critical category in the entire system. Type 2C, the depressed lesion.
So the hammer didn't just flatten the mushroom, it punched a hole in the floor.
It inverted the terrain completely. A type 2C lesion is slightly depressed, sunk down relative to the surrounding mucosa. It looks like a shallow crater or a divot.
The source also mentioned you can have combinations, right? A mixed lesion.
Yeah, because biology is messy. You'll often see a type 2C plus a 2A, so that would be a central depression, the crater surrounded by a slightly elevated rim.
Okay, so we have the full map. Tall mushroom, 1P, squat mushroom, 1SP, the lump, 1SPIS, the low plateau, 2A, the flat spot, 2B, and the crater, 2C.
That's the progression.
Yeah, we have to get to the so what question, because the source makes a very, very specific claim about risk.
This is the pivot point. This is the whole reason for the deep dive. If you're just looking at size, you'd think the big 40-millimeter tumor is the most dangerous thing. Or the big, swinging, pedunculated polyp, because it's so obvious.
Right. Bigger's better. That's just intuitive.
And in the Paris classification, that intuition is wrong. Dr. Raju explicitly warns that the depressed lesions, the type 2C, are the ones that should set off the highest alarm.
Even if they're tiny.
Especially because they are often tiny. A very small 2C lesion is much more likely to harbor advanced pathology than a much, much larger polyp of a different type.
Why? What is it about being depressed about that shape that correlates with cancer?
Just think about the geometry of the colon wall. You have layers, mucosa on top, then submucosa, then muscle. A polyp that grows up, like our mushroom, is growing away from the danger zone.
It's building a skyscraper.
Exactly. It's piling cells up into the open space of the colon. But a depressed lesion, where is it growing? It's not growing up.
It's digging a basement.
It's digging down. It has a vertical axis of invasion almost immediately. Even a small depression implies that the cells are already infiltrating downwards toward the submucosa where all the blood vessels and lymphatics are.
So a type 1P mushroom has this long, safe stalk protecting the body wall. A type 2C crater is basically sitting right on the gateway to the rest of the body.
That is the crucial insight. The depression signals the barrier is already being breached. The source notes these lesions tend to contain advanced pathology, which is doctor speak for this is really bad news, even when they're minuscule.
It's a paradox of visibility, then. The thing that is hardest to see, that tiny little dent in the pink landscape, is the thing that's most likely to kill you.
And this is exactly why the Paris classification exists. It's not just labeling for the sake of it, it's about triage. When an endoscopist sees a 1P, they relax a little. They know the procedure: snare, cut, retrieve.
It's mechanical, but when they see a 2C...
the whole atmosphere in the room changes. They know they're dealing with something aggressive. They can't just snip it off. They might need to do a much more complex procedure to carve it out from the deeper layers, or even send the patient straight to surgery. The shape dictates the entire strategy.
It completely reframes what they do. They're not just cleaning pipes, they're forensic investigators searching for a very specific type of footprint.
They're looking for that discrepancy, that interruption in the pattern, and this classification gives them a shared language. Instead of saying, I saw a weird sunken thing, they say, I identified a 6mm type 2C lesion. Everyone in the room immediately understands the gravity of that.
So it standardizes the perception of risk.
It does. In Dr. Raju's hammer analogy, it helps you visualize that risk profile. As you compress that lesion from 1P down to 2C, you're basically moving from contained to invasive.
The more it blends into the floor or sinks into it, the more dangerous it gets.
Generally speaking, that's the rule. The morphological shift from protruding to depressed mirrors the biological shift from benign growth to invasive cancer.
It's a really powerful framework. Let's just recap that visualization one last time to lock it in.
Let's do it. You start with type 1P, the mushroom, head, long stalk, safe margin.
Hit it with the hammer.
Type 1 SP,
Semi-pedunculated.
short, thick stalk, harder to grab.
Hit it again.
Type 1s, sessile, no stalk. It's a mound that's taller than the biopsy forceps.
Hit it again.
Type 2A, superficial elevated, a plateau that's shorter than the biopsy forceps. And this is where you find those spreading LSTs.
Hit it flat.
Type 2B, the invisible flat lesion.
Oh, flat.
Hit it through the floor. Type 2C, the depressed lesion, the crater, the high-risk zone.
And don't forget the mixed types with the crater and the raised rim.
Right, which visually combines the worst of both worlds.
It's incredible how much clinical information is packed into just simple geometry. Height with depression.
It converts a visual impression into a clinical decision. That is the power of the Paris classification.
And it forces you to look closer. If you're only scanning for big bumps, you'll get the mushrooms, but you'll miss the craters.
And the craters are what you really, really need to find. That is the skill of a high-quality endoscopist, finding the 2C.
This has been a really, really enlightening look at a world most of us hope we never see, but definitely rely on.
It's a visual language that saves lives.
We want to thank our source again for this episode, Dr. G.S. Raju's YouTube. His explanation of the Paris classification really does transform a dry list of codes into something you can see and understand.
It's a great example of how the right analogy, the mushroom and the hammer, can just make these complex medical ideas so much more accessible.
Before we go, I want to leave you with one final thought about that hammer progression. We spent this whole time talking about how the most dangerous lesions are the ones that are depressed and hidden and sunk into the tissue. The big, flashy mushrooms are often the easiest to deal with.
It's the tip of the iceberg, but inverted.
Exactly. And it makes you wonder about the other lesions in our lives, in our jobs, our relationships, our habits. We spend so much energy reacting to the big, loud, pedunculated problems, the ones waving in our faces. But are we ignoring the subtle type 2C depressions, the quiet, almost invisible toxicities that are digging deep into the foundation and causing the real structural damage?
That is a very unsettling but a very valid question. The visible threat isn't always the lethal one.
Just something to think about next time you're looking at a landscape and thinking everything looks flat and fine. Thanks for listening to The Deep Dive.
Goodbye, everyone.